although I'll run quickly, but remember that all of these factors should be, I think, imbibed by every mind who is listening to these, and make a note that this drug, it has become a bestseller, not in mere terms of financial things, but actually in terms of the number of prescriptions being written by the physicians all over the world. And there's not one or two good reasons, but there are 12 good reasons why to use ticagrelor. So we'll pick up those queries one by one. The thing is, earlier on when ticagrelor was launched after Plato trial, there was no recruitment of patients who had undergone thrombolysis for ST elevation myocardial infarction. So there were common queries as to if we gave this medicine to patients prior to hospitalization or in smaller nursing homes, and if they get thrombolized later on, what is the status of these patients going to be? So that became clearer later on, and you'll have the data. I'll present to you slides here. So look at the red slides, which are the patients who received ticagrelor in ST elevation myocardial infarction before reaching the hospital, or as would be applicable in India, these are the patients who would receive the medications in smaller hospitals or nursing homes, and then later on they would get thrombolized. So there are no difference in the outcomes, although, but look at the data which might be of concern. The concern was whether they will cause significant bleed. So the answer is no. Whether within the first 48 hours or beyond 48 hours, ticagrelor loading in patients with ST elevation myocardial infarction before reaching the hospital also or after reaching the hospital does not increase any amount of significant bleed. Look at the topmost two data here. You'll find that ST elevation myocardial infarction, when they receive pre-hospital Brilinta or ticagrelor, you'll find that 30-day stent thrombosis goes down significantly. Similarly, definite stent thrombosis, they go down. So a patient, if they are preloaded with ticagrelor, the majority of these patients are going to have immense benefit in terms of stent thrombosis, and that will be accrued without a significant increase in any form of bleed. Why else can I use ticagrelor? Because if the patients are to be switched over from clopidogrel for whatever reason, I can safely do that. The Plato had a beautiful study design where those patients who had received clopidogrel were not excluded. In fact, they would still be given ticagrelor loading dose, or they might have been continued on clopidogrel, which is in contrast to the prasugrel design. When prasugrel was studied, patients who had received clopidogrel, they were actually excluded. Now we know that in day-to-day practice, people often receive clopidogrel before reaching hospitals or doctors who are more likely to give ticagrelor. So what to do about these patients? Well, the data was quite clear to Plato that you can give ticagrelor in patients who had already received clopidogrel. And again, there was no harm seen in terms of bleed or no adverse drug interaction causing more adverse events. And of course, in Plato, we know it was a landmark study which showed a reduction in mortality and stent-related benefits. So this is the only drug which actually shows, antiplatelet drug which actually shows the reduction in the primary endpoint of CV death, MI, and stroke, and then cardiovascular death is compared against clopidogrel in Plato trial with ticagrelor. You find this happens to be the only antiplatelet drug which actually reduces cardiovascular death on its own. So this is one of the very important reasons why someone is going to use ticagrelor. Then, of course, it has its own unique pharmacology. What you can do is that if patients who are on ticagrelor vis-a-vis patients who are on clopidogrel, when you need to send them for an urgent or early CABG or bypass surgery, you find that because of the reversible binding nature of ticagrelor, the perioperative bleeds are actually significantly less, which is of immense importance because on the one hand, you have an antiplatelet drug which is par excellence, which is very, very efficacious and reduces all stent-related adverse events. Despite that, it is so quickly reversible that just a matter of skipping one or two doses would lead to a significant reduction in bypass-related bleeds. So that's that very important aspect of its pharmacology. Not only this, the importance of ticagrelor is reflected in the data that has been, you know, collected over the period of all these years. This is the drug which has been studied in all the variety of acute coronary disease spectrum. So all sorts of ACS spectrum, be it unstable angina, non-ST elevation myocardial infarction, ST elevation myocardial infarction with thrombolysis, without thrombolysis, or with percutaneous invasive strategy. All of these have been separately or together studied in various trials, and you'll find that whether it is an invasive strategy or a non-invasive strategy, ticagrelor works beautifully and it leads to a reduction in all sorts of events. So you need not to think about the type of presentation of coronary event that the patient has. Irrespective of that, you can go ahead and give ticagrelor with or without aspirin. Then this benefit which is approved by ticagrelor is it's not a time-related phenomenon. It actually persists. So the benefit, you look at the graph, the lower graphs are of placebo, of ticagrelor graph, and the upper one is of placebo. The graph it starts diverging early on within 3 months of therapy. Then you find that it keeps on diverging all through the end of 3 years. So whatever benefits will be happening with ticagrelor, they are not short-lived. They are actually chronically persistent. Now, sometimes patients have not received ticagrelor before coming to the hospital, or even sometimes they have reached the cath table because of sickness of the patient or because of the event of escalation or non-escalation MI associated hemodynamics or whatever reasons, when the patients would not have been loaded with antiplatelet. Such patients, we already have study which shows that ticagrelor can actually be crushed and given to the patient orally or an unconscious patient through the vial tube. Because this has been separately studied, the efficacy is shown to be as good, if not superior, to the oral intake. So this is a significant importance because so many times the patient may not be able to take because they are vomiting or they are on vial tube or they are in ventilator or whatever reason. Even then, ticagrelor, despite being crushed, does not lose its efficacy. In fact, persists on it slightly up. And this is the P2 vital reactivity units with crushed and integral tablet. You will find they all die beautifully. Now, with clopidogrel, one has had events of coronary phenomena because of the unpredictable nature of clopidogrel. Now, that's not really an extremely bad thing, but in a given patient, this might matter. It has been shown that clopidogrel might have a resistance which might range in different populations from 5 to 44%. Even if we take a median number of say about 15%, that is quite a big chunk. And those types of hypo response or the resistance to antiplatelet drug clopidogrel is not reported or is not seen with ticagrelor, which makes it a more predictable and highly efficacious drug. Now, of course, with prasugrel, one has seen, not much less with clopidogrel, one knows that there are certain contraindications, but there are certain group of people or set of patients who might actually have harm rather than benefit by using prasugrel. So that's another, say, reversibly seen to be a beauty of ticagrelor because those contraindications they do not exist with ticagrelor. Namely, these three important ones. One is a history of TIA or stroke, which in prasugrel trials are shown to increase the intracerebral bleed significantly. So patients who have had a history of TIA or stroke, whenever in the past, they sort of work like a contraindication for prasugrel therapy. People who are older than 75 or who are lean and have a weight of less than 60 kilograms, either you have to cut down the dose to 5 milligram empirically from 10 milligram, or you may choose not to give prasugrel. Any of these three contraindications, and there is another fourth which is not mentioned here, which is of renal dysfunction. So patients who have renal failure adversely with prasugrel. All of these four contraindications or precaution or words of caution, they do not concern ticagrelor. So you can actually simply pick and choose ticagrelor for every single patient of yours without minding any of these factors as we discussed with prasugrel. And here you'll find that for stroke in high advanced age and low weight, you'll find the prasugrel was actually worse compared to this. We have seen that all sorts of atherosclerosis. Now, all sorts of atherosclerosis, we have patients who have undergone PCI. We have seen patients who have not undergone PCI, patients who have ST elevation or non-ST elevation, people who have received or not received blood. All of these patients have been studied. And another thing which you will not see on the screen right in front of you, which has been presented very recently, a week back, the American Heart Association meeting, was that ticagrelor is now shown to reduce stroke in patients with myocardial infarction or atherosclerotic vascular disease. That is another big, added bonus here, because uh, most of the times you are afraid of giving dual antiplatelet therapy, especially for patients who have a neurological issue. And here, Brilliant again is shown to be superior to clopidogrel. Not only superior, it has actually shown that strokes might be much less in patients receiving ticagrelor post-MI. Then, of course, we have seen that the platelet inhibition as compared to clopidogrel is not merely uh, more linear, and there are no issues of having drug resistance. The overall antiplatelet efficacy as compared to clopidogrel is definitely superior. Now, the biggest advantage that you'll find here is that you'll find patients in your clinical practices who receive aspirin and ticagrelor. You find that they come with nuisance bleeds like dental bleed, nasal bleed, subcutaneous purpuric hemorrhages, subconjunctival hemorrhages. And of course, in patients who have received long stents or multiple stents, one is quite wary of not one doesn't want to stop antiplatelets. So here one has very reasonably good data which shows that in patients as early as 1 week post post stenting or MI, one can actually completely stop aspirin and just continue ticagrelor. That alone is shown to be as good as receiving dual antiplatelet therapy. In fact, there is some now there is a lot of data actually which is being gathered which shows that single antiplatelet ticagrelor may be superior to a dual antiplatelet, especially in a high risk population. So patients who are at high risk of bleed can be safely given single antiplatelet in the form of ticagrelor, and you can simply get on ahead without using aspirin. So I told you these are a good dozen reasons why one would like to use ticagrelor, and as I show, as you can see here, that single integrated ticagrelor is almost as good as using dual integrated therapy, and that happens without any burden of skin clearance. So it can be used, ticagrelor can be used pre-hospitalization. It can be used because it gives mortality benefit over clopidogrel, can be given on top of clopidogrel. One doesn't have to mind too many precautions as one does with prasugrel. Can be chewed or can be given in crushed form through rice tube, can be given in all sorts of acute pulmonary atherosclerotic vascular events, whether patients are in an invasive strategy arm or a non-invasive strategy, can be continued for long, and the benefits can be kept occurring till even at the end of 3 years of therapy. And of course, it might actually be the antiplatelet drug which can be continued, and all other antiplatelets can be concurrently needed to be given when one is using ticagrelor. Thank you so much. These are the factors that I needed to discuss with you, and I'll be happy if you have any questions or queries.
Sir, so shall we wait for few minutes for questions?
Yeah.
Okay, so now you have to stop sharing screen. You
Okay.
have to click on stop sharing. Yes.
clopidogrel.
Sir, there is one question in chat box.
Yeah, tell me. Chat. What's your preference, drug in ACS, Ticagrelor, or which? Unless stated otherwise, I think in last more than 5 years, the drug that we use along with aspirin in all invasive or non-invasive patients is always Ticagrelor. Clopidogrel is only started in post-angioplasty patients after a couple of months or 3 or 4 months when cost issues might crop in. Otherwise, everybody gets to receive Ticagrelor and no clopidogrel. It does not mean that clopidogrel is a bad drug. It's an excellent drug. It has proven its superiority over decades. We were the uh, we are that batch of interventional cardiologists who had actually started with aspirin alone, had lots of stent-related problems. Then we had aspirin followed along with ticlopidine, which went into disuse immediately within few months to years because of the side effect of agranulocytosis. And then, of course, with the cure and PCI cure trial, we had clopidogrel, and that was like a magic bullet to all the people who are practicing interventional cardiology. So, absolutely beautiful drug, clopidogrel, but then, of course, there is always room for improvement, and ticagrelor has shown that it is distinctly superior to clopidogrel by all means. So, barring the cost, I don't think there is any reason for anybody not to use ticagrelor. So, I think that's all. Thank you, everyone.
Okay, sir. So shall we wait or wind up?
No. I'm not covered.
Okay, sir. So on behalf of the organizer, we would like to thank you so much for your insightful and educative talk, sir. Thank you so much, sir.
Thank you.
And from here, I am ending the session now.